Chairman Guthrie and Ranking Member Eshoo, and to the committee for including two pieces of legislation, H.R. 5539, the Orphan Cures, and H.R. 5547, the Mini Act. In this hearing, these are critical pieces of legislation to the future of patient treatment and to the access to cures in the rare disease space. Both bills, which represent narrow and concise fixes to the IRA to ensure that research and treatments and future innovation that American patients want and American patients deserve are recognized. I want to be clear on what these legislative efforts represent. These are not in any way meant to undermine or alter the fundamental negotiation mechanisms that were passed in the IRA, but rather drive more investment into the rare disease space to develop the next generation of cures and the next generations of therapies in diseases like Merkel cell carcinoma, in diseases like glioblastoma, and give patients and their families hope. The Orphan Drug Act was signed into law the same year that I graduated from medical school, and I have been able to witness firsthand the life-changing and significant innovations in treatments and cures because of that act. The diagnosis of metastatic melanoma that previously carried with it too frequently a referral into hospice care in short order can now be treated, and patients can go on to live. Of note, the first cellular therapy for metastatic melanoma was just announced this month. In fact, since the passage of the Orphan Drug Act, almost 1,200 new medicines have received FDA approval with orphan designation. I hope that everyone on this committee, regardless of party affiliation, wants the level of innovation to continue in treating diseases. I'd also like to add that the passage of the IRA, the orphan provision in Section 1192, is an acknowledgement that orphan disease treatments are meant to be shielded from the negotiation protocol, and that the bills we are considering today is merely an effort to improve that exemption for the patients who ultimately will receive treatment from these future innovations. In a similar vein, the Mini Act narrowly targets therapies utilizing genetically targeted technologies, or GTTs. GTTs were defined for the first time in the 21st Century Cures Act and capture two categories of genetic therapies akin to the biological technologies, small interfering RNA and antisense oligonucleotide. GTTs are still in their infancy, and subjecting these highly complex small molecule drugs to negotiation timelines intended for simpler drugs will disproportionately impact the innovation ways to treat diseases with high unmet medical need. Rare diseases are those defined as affecting fewer than 200,000 Americans, and while rare diseases may individually impact a relatively small number of patients, collectively their impact is far-reaching, affecting 30 million Americans, or roughly 1 in 10. In 2023, research resulted in 71 novel approvals, including new treatments for rare and hard-to-treat conditions. Personally, I am the survivor of a rare pediatric cancer. I lived, and that impact still impacts me every day. Dr. Chen, from an economic perspective, can you speak to the value of post-approval research into additional indications and what that means for patients specifically in the rare disease community?
Absolutely. So the post-approval pipeline of R&D is a much more cost-effective way of doing R&D. You already know what the drug is. It's been approved for one indication. And the ability to test that drug in multiple other rare disease indications is valuable because the incentives to do that might not have been there if you had to develop the drug from the start all the way at the very beginning of this process.
Finally, Ms. Davis, thank you for being here. Thank you for sharing the story of the loss of your husband due to glioblastoma. Can you speak to the importance of continued progress of rare conditions for your family and the rare disease community?
I apologize. With 95% of rare conditions lacking an approved treatment, we must continue to drive innovation so patients with unmet needs can access the treatments for their conditions.
To conclude, thank you to all the witnesses, and know that patients can only access and afford orphan medications if they first exist. Thank you, Mr. Chairman, and I yield back.